A very good morning. I'm just going to show you two cases because there was a question asked right in the beginning that we do have OCT angiography now. So we see something new, we don't know what it is, how do we compare it with the gold standard, and how do we know what we are seeing is right or it's just one of the findings. So let's go over two patients where I'll show you how angio OCT helped us in managing these patients. Now look at this fundus picture, right and left eye of a 22-year-old girl. She has been treated outside as serpiginous choroiditis, but she has a very distinct complaint. She says she has a recent metamorphopsia. When we look at the fundus, we do see there is some amount of subretinal fibrosis here, and the healed lesions. But we do not see any evidence to suggest that there is any active lesion. So she has received treatment for TB choroiditis earlier. She is complaining, mainly the complaint of metamorphopsia is in the right eye. We do OCT. We look at this, which we thought could be a choroidal neovascular membrane, but we did not see much of the fluid or leakage. We did an ICG. ICG, like Dr. Reema showed you, a beautiful network on ICG of CNV. We did not see a very clear-cut network that could be suggestive that there is an underlying choroidal neovascular membrane. And this is the late phase, except for this dot, which was coming in the late phase as hyperfluorescent. We normally did not see anything on fluorescein. And on ICG, we did see some hyperfluorescence here, but again, we did not see that classic network. Now the question is, there is a lot of choroiditis which is healed. There is complaint of recent metamorphopsia. You are in doubt based on the OCT image. You're not too sure whether it is a membrane or not a membrane. Would you inject or would you not inject? This is where the OCT Angio helps you in making a clear-cut decision. This is the Angio OCT, which shows a beautiful neovascular network, which you are, without any doubt, you are sure that it is a choroidal neovascular membrane, which is growing under the scar. So this is the patient who requires anti-VEGF injection. This is again to show the neovascular net on angio OCT. This is patient receives injection, and this is post-injection showing some regression of the net. Any questions related to this particular case? Yes.
The decision on treating was definitely helped by OCT angio, but I think you also gave a lot of weightage to her symptoms, like in a myopic CNVM. Many times we don't see anything objectively. We give a lot of importance to patient who's very wise, and he says that since last week I'm getting metamorphopsia, and we tend to treat. So did you give equal weightage to her symptoms? And what I mean is, suppose you had seen this and the patient had no symptoms, would you treat that, or you gave 50% importance to the symptom also?
We have a series coming up in the Retina Journal where we have said that if the patient is symptomatic and you are suspecting there could be an underlying neovascular membrane, and amidst all this hullabaloo of scarring or a bad fundus, you are not able to pick it up, you cannot rule out CNV unless you have done OCT angio. So I hope that answers. Yes, Vishika.
Just want to understand how a subscar net causes metamorphopsia.
How?
How this subscar, the scar is underneath the retinal this layers. And there's no fluid in your pictures. So how the photoreceptors and all the metamorphosis is happening? Where the fluid is coming into the tissues or what,
Yeah.
or we cannot see them.
Yeah, what is happening is when there is a scar, just adjacent to the scar, there is probably a dehiscence. So we are actually seeing type 1 choroidal neovascular membranes in many of these patients. To begin with, they may have very small microcyst in the retina. We have both group of patients. Some we have treated, some we have not treated. Those whom we have not treated have progressed on to develop the fluid subsequently and worsening of the vision.
Probably this helps to treat early and get better results.
That's right. With this, I move on to my next case. This is a 35-year-old man who comes to us with complaints of hemicranial headache. And you can see there is a zoster going on there. So he gives history of decreased vision in both the eyes, which is painless progressive, no other positive history. Now, when we look at the fundus, it shows few hemorrhages, some whitish lesion, and this lesion here, like it's a patient with zoster, so our first thing was, is it zoster-related retinitis? How many of you feel it could be retinitis due to zoster? His vision is down, there are no cells, and we do the angiogram. The angiogram shows some vascular involvement here. There is very mild leak from the blood vessels here. And in the right eye, again, you have mild vascular leak here. We do the OCT. OCT actually showed vitreous cells better than what we could appreciate clinically. There were hyperreflective lesions in the outer plexiform and outer nuclear layers, and we could see cystoid spaces. There was also disruption of foveal contour here, like foveolitis, with hyperreflective lesions involving all retinal layers at the fovea. So what do you think this patient has? Now, these are the findings which are very typically seen in patients with dengue. The patient did not come to us with history of dengue fever. He came with herpes zoster, so we were looking for herpes. But honestly, when we looked at the OCT, we say, oh, it looks like dengue maculopathy. We did the OCT Angio. OCT Angio showed loss of superficial capillary plexus with irregular parafoveal microvasculature and significant loss of deep capillary plexus. This loss of capillary plexus on angio OCT too is seen in dengue maculopathy, and that is why some of the patients, despite steroids, do not improve vision. Now the patient gives history of fever. He was diagnosed as dengue NS1 10 days ago. He also has thrombocytopenia. So he did show improvement on steroids, and this is the follow-up. Decrease in vitreous cells, reduced cystoid spaces, mild thinning of outer plexiform layer, and you can see on follow-up reversal of the changes. So this is the follow-up. No significant change in the perfusion of the superficial plexus at 6 weeks, and no significant change in vascular perfusion of eyes with dengue maculopathy despite oral. So some of the inflammatory components can be taken care of, whereas ischemic insult is invariable. So this is something we are publishing again, is dengue-induced ischemic inflammatory foveolitis and outer maculopathy, again something which we have named the entity based on Angio OCT and OCT. Thank you very much.